Welcome, I'm Dr. Rutchik, and this is segment 2 of 3, entitled Occupational Neurology for the Primary Care Provider, Post-Concussion Syndrome. In our first segment, we described a patient with mild head trauma who had a past medical history of depression and mild head trauma, who presented with a seizure and was placed on anti-epilepsy medications. We discussed her clinical exam. My name is Dr. Jonathan Rutchik, and I'm a neurologist as well as an occupational medicine physician in San Francisco. This is a picture of me. So we'll continue our discussion with nystagmus. And the first question when one notices nystagmus on an exam is whether it's acquired or congenital. Nystagmus is unilateral or unidirectional horizontal jerk, which is maximum on a lateral gaze. The slow phase usually points to the abnormal side. Now, nystagmus is normal when gazing to greater than 30 degrees. That is, if you place your finger in front of the patient and ask them to look all the way right, and only one eye is looking at the finger, you may very well notice monocular nystagmus, and this is quite normal. Congenital nystagmus often improves with convergence, but does not change with gaze. One now will ask whether the nystagmus is peripheral or central, and it is important to note that peripheral nystagmus can be suppressed with fixation, while central is symmetrical, does not fatigue, and is associated clearly with other brainstem findings. Nystagmus that is downbeat suggests Chiari malformation or anticonvulsant toxicity. One that is upbeat may suggest an acquired brainstem localization. BPPV, or benign positional vertigo, is a common described condition in our population, certainly in the population which has head trauma. It may be associated with a virus, but important to note is the vertigo begins with motion, and patients usually complain that I developed vertigo when I stood up or turned my head. The vertigo may last for 5 or 15 minutes, and bouts, however, may last for weeks or months. The Dix-Hallpike may be the method of diagnosing such a condition, BPPV, and after one does not make that diagnosis, treatment with the Epley maneuver is very, very safe rather than with any other kinds of medications, and can be easily taught to a patient. This is a great demonstration of the Dix-Hallpike. It's important to note that the nystagmus has a latency, is upbeat and rotatory, and its duration is 15 seconds when one places the patient's head off the side of a table. This is a visual for the Epley maneuver, and you can teach your patients, or you can refer a patient to a physical therapist in order to be taught. And it's very, very helpful for patients with any kind of vertigo. Now, patients with head trauma may have sensory complaints, but it's important to note that you're always trying to rule out some underlying condition. Patients who may have facial sensation with pain, it's encouraged to do a gag reflex or a blink test, so as to uncover any other brainstem findings. Reduced facial sensation along with pain may be a presentation of multiple sclerosis in a female under 35. But entire hemi-body sensory loss may be suspect, and placing a tuning fork on the sternum or forehead may reveal that the patient finds that one side is different from the other, and this clearly is not physiologic and may support exaggeration. However, it doesn't really support that there's no pathology, so it's important to continue to be thorough and be a good historian. Patients who are placed on anticonvulsants after mild head injury are not common unless there's been a seizure. If there's been a subdural or epidural hematoma, seizure medications may in fact prevent post-traumatic seizures for an approximately 1 month period of time. And the goal would be to choose the lowest side effect profile for that patient. Patients actually may get an emergency room load with Dilantin if they have a seizure, and this may lead to them having medications for 6 months. Clearly they would need an MRI and an EEG, and it's important to remember that patients who do have abnormal EEGs or MRIs after their seizure may very well have a higher predictability for a second seizure, or then therefore maybe a diagnosis of epilepsy, than one with normal EEG or MRI. This is a list of anticonvulsants, just reiterating that these do bring side effects, or many patients do develop side effects with these medicines, and they vary from ataxia to tremor to weight gain to cognition issues and irritability. So read a lot about your medication before you think about prescribing, and even if you acquire a patient with a medicine like this, try to learn what they are. The workup for syncope and seizure includes EEG and MRI, but also sleep-deprived EEG, and also a cardiac workup, including a coagulopathy screen. A sleep-deprived EEG may very well also be associated or be, in tandem with a video EEG, especially when there's psychogenic seizures is of interest to rule out. So, primary consultations in the setting of mild head trauma or post-concussive syndrome includes neurology, where the question of a blink study is indicated, laboratory testing for anticonvulsants. Did I choose the right anticonvulsant? Do I need an MRI of the brain or an MRI of the cervical spine? ENT to consider audiology or ENG testing. Ophthalmology for acuity testing, possibly uncovering a presbyopia or visual field testing. And the dental consultation is also helpful. You may very well have people who acquire TMJ, so a head and neck exam is important to find out whether they have clicking in their jaw, or you may uncover they have had TMJ or have had bruxism prior to this trauma, and so these things may be, leading to delayed recovery, or at least, involved in the delayed recovery process. So treatment may be helpful. Physical therapy, again, talking about the Epley maneuver, possibly acupuncture and chiropractic care. Psychology and neuropsychology, aiming at treatment, maybe biofeedback, clearly anesthesiology relating to possibly an epidural or an occupational neuralgia, occipital neuralgia injection, I should say. Treatment for headaches, it's important to note that narcotics are not the way to go. Antispasmodics are also, short-acting and can lead to medication overuse headache. Encourage simple medicines, ice, NSAIDs, rest, and butanol. For dizziness, encourage reducing activities and increase the activities when the dizziness improves. Limit the use of meclizine. It's sedating, all kinds of other side effects with the medicine. For nausea, consider that opiates may be contributing, of course, after a brain imaging is normal. For headaches, it's important again to remember that migraine medications are not the best choice for trauma-induced headache. Amitriptyline, nortriptyline, doxepin are great medications for patients with chronic sleep pain and mood issues, possibly antidepressants in a family of SSRIs, or even the anti-seizure medicines, Topamax, Lyrica, and Neurontin. Other anti-seizure medicines such as Dilantin, Tegretol, and Keppra may be helpful for the sharp pain and headache. Clearly, a headache journal is key. Now, there's many headaches out there, many types of headaches, but it's important to know your definitions. Migraine is usually unilateral, severe, throbbing, associated with nausea, vomiting, photophobia, phonophobia. Sometimes there's no or though. Other kinds of headaches, chronic tension type headache, bilateral, pressing but not aggravated by activities, new daily persistent headache, acute onset and constant, hemicrania continuum, maybe unilateral, greater than a month, lack of a precipitating event. Also autonomic features. There may be cervicogenic headache, whereas headache comes from the neck, and maybe there in fact is some occipital neuralgia or occipital notch focus of the pain. In some of these patients, injections may be helpful. Also, chiropractic relief is poorly studied, but also may be helpful. But most important is to consider that medication overuse headache is extremely common. Other terms include rebound headache or drug-induced headache. This is defined as anybody with headaches more than 15 times per month, and they use short-acting medications for pain. 1 to 2% of the population have this type of headache, and the key is to avoid barbiturates, caffeine, codeine, or tranquilizers, as well as any mixed analgesics. So, again, I'm Dr. Rutchik, Neurology, Occupational Medicine in San Francisco Bay Area. This concludes segment 2 of our video series, Post-Concussion Syndrome, and I encourage you to, the viewer, to access segment 3 as well as segment 1